in this section, we are going to talk about approach to a patient of breast lump. Now, before we go on to talk about approach to patient or breast lump, we need to understand one thing here, that surgery being a clinical subject, and for that matter, in any clinical subject, there are going to be three issues. One, theoretical aspect. Two, clinical aspect. And third is a practical aspect. Now, in our exams, they have started asking you about the clinical and the practical aspect more often than the theoretical. They were always asking a question on the theoretical aspect, but they have started asking questions on the clinical as well as the practical aspect now. Now, these theoretical, clinical and practical aspects are different, but yet they are integrated. Now, what is the difference and how are they integrated? This is something we have to understand here. When I say theoretical aspect means a theoretical aspect question will be, what is the most sensitive investigation for this particular pathology? What is the most specific investigation for this particular pathology? What is the investigation of choice for this particular pathology? But when it comes to the clinical aspect, which is quite different, and you can appreciate it also, as a clinician, when the patient comes to us, we don't think about what is the most specific investigation here, what is the most sensitive investigation here, what is the investigation of choice for this particular pathology. What we think about when a patient comes to us, that what is the relevant investigation suitable to this patient's profile. So we cater investigation to the patient's problem. This is what is a clinical aspect, and there is a gap here, and this gap many times students find it difficult to understand, and we have to bridge this gap because now they have started asking questions on these aspects majorly. And then comes the practical aspect. The practical aspect is how do we do that investigation per se. So we will try to bridge that gap here in this discussion on surgery. I am a strong believer of a concept-based teaching because I believe if you know the right concept, whatever is the language of the question, because surgery being a clinical subject, a slight change in the language of the question makes a gross difference. So if we know the right concept, then only we'll be able to figure out that slight change, which quite commonly happens in our exam. So let's get started here on approach. This is how the things go in our discussion on surgery also. So let's try to bridge that gap between theoretical, clinical and the practical aspect. So let's get started here. Now, first of all, before we proceed to approach to a patient of breast lump, we need to understand there can be three types of patients who are coming to us with breast lump majorly. One is a patient from a normal risk population, normal population patient. Second, a patient who is a high risk patient of breast lump. And third can be a pregnant female coming to us with a breast lump. And then there can be a patient who is coming to us with breast lump with a nipple discharge. Now, we can only talk about the nitty-gritties of the approach in a patient of breast lump, the hi-fi things of a patient of breast lump, only when we know the basic thing. Because I believe that if you have the strong base, then only we can build on the hi-fi thing. So there is no point talking about a hi-fi without understanding the basic things. So let us first talk about how do we go about, what is the basic approach in a normal population patient. So we will talk about a normal population patient here first, then we'll talk about a high risk patient. What is high risk patient? What is the definition of high risk patient? We will discuss later. So let's talk about this first. Now, to understand the approach, we have to first know that the investigations in breast are primarily divided into two types. Non-invasive investigations and invasive investigations. Non-invasive investigations and invasive investigations. Non-invasive investigations in breast includes, first of all, basic, preliminary, non-invasive investigation. What is this basic, preliminary, non-invasive investigation and why it is important for us to know? Everything has a relevance here, and this discussion on surgery I can assure you on this that once you understand this, you will have no problem in answering majority of the question in your exams. Now, basic non-invasive investigations include ultrasound and mammogram. Ultrasound and mammogram are the basic non-invasive investigations. While there is another category of investigation in non-invasive, that is advanced non-invasive investigations. Advanced non-invasive investigations include MRI, lymphoscintigraphy, PET scan, and now we also have a PEM scan. Now, what is PET scan? What is PEM scan? What is the basic difference? We will talk about in the theoretical aspect also, but at this time, you just need to know that these are the advanced investigation, and then we also have CT scan of the breast as another advanced investigation. We primarily do for soft tissue MRIs, but then CT scan is also coming up for breast as an advanced investigation, right? Then comes invasive investigations. Invasive investigations in breast includes FNAC and biopsy. Invasive investigation in breast includes FNAC and biopsy. And there are three types of biopsies. There are three types of biopsies. Core needle biopsy. This core needle comes by the trade name called TrueCut. The trade name of this core needle is TrueCut. So sometimes this core needle biopsy is also called TrueCut needle biopsy. Then we have incisional biopsy. We have excisional biopsy. We have incisional biopsy. We have excisional biopsy. Now, first of all, how to decide what to do first? What are the other issues in this approach? We have to first understand here that whenever we have to do a non-invasive investigation, every statement has a relevance here. Whenever we do a non-invasive investigation, the guideline says we should always do first a basic preliminary non-invasive investigation. Now, when to do that non-invasive investigation, we'll understand here. But what we first need to understand here is that we should always first do a basic preliminary non-invasive investigation if an issue of non-invasive investigation comes in a particular patient's approach. This is one thing we have to first understand. We are talking about a normal risk population. So first we need to have the base of normal risk. How do we go in a normal? What we do in high risk, the basic thing remains same. There is slight change here and there happens when we go to the next level. So this is one basic point about the non-invasive investigation. Now, first of all, let us talk about invasive. We'll come back to non-invasive later, but let us talk about invasive investigation. Now, if I ask you a question, this question will be very simple for you to answer now, that out of FNAC and biopsy, FNAC is fine needle aspiration cytology. Out of FNAC and biopsy, which of them do you think is better? Obviously, your answer will be biopsy. Why so? Because in FNAC, we are examining cells, while in biopsy, we are examining tissue. Now, since we are examining tissue in biopsy, so obviously the information we are going to get on biopsy through tissue will be more than what we otherwise get through a cell. So obviously biopsy is better. Now this will not be right, and this is not the way I also go about. If I ask you question on these three types of biopsy without making sure that whether you know what are these biopsies actually. So we should first know what is core needle biopsy, what is incisional biopsy and what is excisional biopsy, then only you will be in a position to understand that which is the better one here. So let us, and what are the issues with this biopsies. So let us first talk about a core needle biopsy. Now, core needle biopsy, as the name suggests, this is a needle with a big core. Inside this needle, there is a knife-like thing. Inside this needle, there is a knife-like thing. So when you press a plunger from outside, this knife-like thing comes out. And when you pull the plunger from outside, this knife-like thing goes into the hollow component of the needle. So when you are pressing the plunger, the knife comes out. When you pull this plunger, the knife goes into the hollow component of the needle. Now what we do, we have a lump here. Imagine, and there is a skin overlying the lump. So what we do, under local anesthesia, we give a small incision over the skin overlying the lump. Then we insert this needle with a sharp knife-like thing pointing out. With a sharp knife-like thing pointing out, so that the passage through the tissue is easier. Now, once this needle is inside the lump, we pull this plunger. When we pull this plunger, the sharp knife-like thing will be inside the hollow component of the needle. So it will be something like this now. So we have pulled the plunger. Now what we do, we are going to steady our left hand through which we have pulled the plunger. Now we advance the outer core of the needle further with our right hand. Now needles are made up of stainless steel. So when this outer core goes ahead, it will chip off the tissue present in the lump, and that strip of tissue will come into the hollow component of the needle, and then we take the needle out. And then once we press the plunger, the tissue is on the slide. So this is what actually a core needle biopsy is. Now what is incisional biopsy? As the name suggests, there is a lump. What we do, we give a big incision over the skin overlying the lump, separate the tissue over the lump, then we reach to the lump and take a chunk of tissue from the lump, and once we have taken out the chunk of tissue from the lump, then we suture the skin back. So this is what is incisional biopsy. Now what is excisional biopsy? As the name again suggests, excision, you should know what is excision. Excision, whenever a term used, it means whenever you take out a pathology with a rim of normal tissue around it, a small rim of normal tissue around it, the term used for this kind of removal of a pathology is called excision. So what we do, there is a skin overlying the lump. On this skin overlying the lump, we give again a incision, and then we separate the layers, and then we take out this lump with a rim of normal tissue around it, and then we suture it back. The skin overlying the lump then is sutured. Now, with this understanding, now is a right time actually to ask you this question. You have already answered out of FNAC and biopsy, which is better? It is biopsy. But now is the right time to ask you, out of core needle, incisional and excisional, which of them do you think is the best? It is now very easy for you to answer. It is the excisional biopsy. Without any confusion, you can make out is the best. But having said this, if I ask you a question in this way now, the language of the question is going to be the key in exam, and most of the time examiners play with this language. If I ask you a question out of true cut, incisional and excisional biopsy, which of them you will prefer doing? Which of them you will prefer? Now it is not about the best, it is about prefer. Obviously your answer will be true cut biopsy. Why? Because you are getting the information also about the pathology at the same time with a minimum insult to the breast tissue. So it is now easy for you to know that if a question comes, what is a preferred biopsy? Your answer is going to be core needle. If a question is on best biopsy, the answer is going to be excisional biopsy in exam. And incisional biopsy, you should know, is no more done in breast. So what we have understood from here, that excisional biopsy is the best, while true cut biopsy is the preferred one. Now, having said this also, there are very few. Excisional biopsy though is the best, but there are only few instances where we actually get to do excisional biopsy. So we should know what are the indications of excisional biopsy. The indications of excisional biopsy are indications of excisional biopsy are 1. When a true cut biopsy is inconclusive. When a true cut biopsy is inconclusive. 2. When there is a atypical hyperplasia. Atypical hyperplasia. That atypical hyperplasia can be ductal hyperplasia. That atypical hyperplasia can be lobular hyperplasia. We'll be discussing that in the theoretical part of the discussion on the benign disorders of the breast. 3rd, when there is a lobular carcinoma in situ. When there is a lobular carcinoma in situ, then also we should be doing an excisional biopsy. 4th, when there is a sclerosing adenosis or radial scar in our true cut biopsy. What is sclerosing adenosis, radial scar? We'll be talking about. And 5th, when there is a papillary lesion. When there is a papillary lesion, these are the indications of excisional biopsy. Now, with this understanding now, this is quite a simple question for you. If a question comes, which was a question also in your exam, that the patient has come to you with a breast lump and found to have a atypical ductal hyperplasia on true cut biopsy, what is your next step? Now, you can easily appreciate your answer should be excisional biopsy. Now, correct me if I am wrong. We have just said that the excisional biopsy is the best. Correct me if I am wrong. Can I say here that though excisional biopsy is the best, but there are only few, these are those few instances where we actually do excisional biopsy. So can I say further on this, that when it comes to the invasive investigations in breast, it most of the time boils down to FNAC or true cut biopsy. In few instances only we do excisional biopsy. So it actually boils down to FNAC and true cut biopsy. So let us know few things about FNAC and true cut biopsy, because ultimately in an approach to a patient of breast lump, we have to decide when to do what. So we should know the basic things first. FNAC and core needle biopsy. In FNAC, what is the size of the needle we use? Again, they have started asking those practical questions. So we should know the size of the needle we use here is 22 to 27 gauge needle. And very commonly, they don't give you choice of range, they give you a specific number. So 22, 23, 24, 25, 26, 27, if the number is there in the choice, commonly, since we use 23 gauge needle, answer should be 23 gauge. Now, what is latest in FNAC? That also we should know. A new thing which has come up in FNAC is FNNAC. Now, what is FNNAC? FNAC is fine needle aspiration cytology. FNNAC is fine needle non-aspiration cytology. Now, what is realized over a period? Now that in FNAC, what we do, we insert a needle and we apply a negative pressure. And with the negative pressure, what happens? Because of the pressure, the cells have to squeeze into the hollow component of the needle. Now, because of that squeezing in of the cells into the hollow component of the needle, the morphology of the cell gets distorted. So because of that, seeing details in the cells internally because of the morphology got distorted, it becomes sometime difficult. Now with FNNAC, what we do? We insert a needle into the lump or a pathology and let the needle be there for some time so that the cell come into the hollow component of the needle through a capillary action. So with this, the morphology of the cell still remains preserved. So this is something coming up, but at this time, we should know, can be a question in exam. This FNNAC is very commonly applied in thyroid conditions, because in thyroid, we are majorly dependent on the medullary cell, papillary cell. They have certain features. So FNNAC at present is readily applied in thyroid condition, but then it is also being tested in other pathologies also. So can be a question in exam. Now core needle. Now core needle, there are two types of core needles we have. One is the semi-automated or automated core needle, which we commonly use, and we also have a vacuum assisted core needle. Now, why it is important for us to know? Because they can ask question in any which way. The core needle, the routinely used core needle we have is having a size of 14 to 16 gauge. 14 to 16 gauge is the size of this core needle which we routinely use. And if again the range is not there, the commonly we use a 16 gauge needle. Again a question in exam. Important. Now in vacuum assisted core needle, we use 8 to 11 gauge, and commonly in that we use 8 gauge needle. So how to answer a question if the question is about a core needle? If it is not mentioned about a vacuum assisted and asked which size core needle we use for breast lumps, answer will be according to what we use more commonly. So that means the answer should be 16 gauge. But if they specify vacuum assisted, if the range is there, it will be 8 to 11. If the range is not there, we use 8 gauge vacuum assisted needle commonly. Now this is how the core needle look like. This is a automated core needle which we use, and this is how the core of a tissue is taken. So because there are image based question in exam, so we are commonly checked on these things. So we should know how a core needle looks like. This is how a core needle looks like. Right? Now coming back. So FNAC and true cut biopsy we were talking about. So let us know what are the issues with FNAC and core needle biopsy. Now, first of all, we can easily appreciate this procedure is going to be less painful. This procedure can be painful. In this, there will be no scar. In this, there will be a scar. Now, what is the major problem with FNAC, which you also know already? In FNAC, you cannot differentiate in situ from invasive cancer. Now, why can't we differentiate in situ from invasive? Because in situ and invasive, to differentiate, we need to know the basement membrane invasion. And in FNAC, we are examining cells. And in the cells, we will not know if we don't have a basement membrane, whether these cells are above the basement membrane or below the basement membrane. So it cannot. While core needle biopsy can easily differentiate invasive from in situ. Then, very important, as I said, every statement will help you in reaching an answer in exam to a question. It is very difficult. It is very difficult, but not impossible. Mind it. It is very difficult to assess ER, PR, receptor status through FNAC. Now, what is this ER-PR? We will be discussing in the management of carcinoma breast. So, it is very difficult, but it is not impossible to find out the ER-PR receptor, while it is very easy in true cut biopsy. Then comes a very good advantage with FNAC we have, which without a scar we get the information. False positive. Again, a question in exam. False positive are very rare in FNAC. False positive means if FNAC says that it is malignancy, it is malignancy. Because if the pathologist is seeing a cell under the microscope having a feature of malignancy, he is not having a deja vu. So, FNAC, very less chances are there that it will be falsely positive. Likewise, true cut biopsy also will not be false positive, very rarely. But there is a very big disadvantage we have with FNAC, which also a question in exam. False negative in FNAC are very much there. Means if it says that it is benign, it can still be malignant. Why does that happen? We are using a very fine caliber needle, so it is quite possible the area from where the cells have come, the cells which have come are benign cells only, because there is a admixture of benign and malignant cell in a malignant pathology. So only benign cell came out. So it turned out to be benign on FNAC, but it is actually malignant. Can there be an issue of false negative in true cut biopsy? Yes or no? It can be there, but very less likely. Very less likely. Now, this is another important point. Again, a practical aspect. Again, can be a question in exam, and we should know this. To avoid this false negative result in the core needle biopsies, there is a recommendation of the minimum number of cores to be taken in any particular pathology also. In, say for example, in breast, the minimum number of cores ranges from 5 to 12. It is said that between 5 to 12, any number of the samples of core strip of tissue we should take. And if you have to select one, better answer will be 5. We should take minimum of 5 cores. Now, what does that 5 for means? We have a lump, we have inserted a needle, right? Now, we have taken a strip of tissue from the lump. Now, we take the needle out. Now, through the same incision on the skin, we will not give a different incision. Now, we insert this needle in the different part of the lump. And likewise, we take 5. So, for every pathology, there is a recommended number of samples in core needle biopsy. Like in prostate, it is 12. Again, can be a question in exam. So, we should know these practical aspects also now. So, this is about the FNAC and core needle biopsy, right? Now when to do what? We will figure out further. This is the basic thing. Without understanding this base, we can't talk about the approach, because we struggle on these approach based questions majorly. So we have to have a base. Then comes the non-invasive investigation. So let us first start with ultrasound and mammogram. Now, before I tell you about ultrasound and mammogram, as it is, we can appreciate advanced investigations like MRI. At this time, because we have a theoretical discussion later, at this time we just need to know one thing, that advanced investigations are going to be more sensitive. So MRI is actually the most sensitive investigation in breast, right? Now, how does this bridge of most sensitive and the approach is filled? We are trying to figure that out. Now, let us first know the basic issues with ultrasound and mammogram. Mammogram, first of all, are of three types. What are those three types? Conventional, film screen mammogram, conventional film screen mammogram. We have a digital mammogram, and now we also have tomosynthesis. Conventional film screen mammogram, digital mammogram, and tomosynthesis. Now, first of all, MCQ point. Earlier, we were doing conventional film screen mammogram. Now, we commonly do digital mammogram. There was a question asked, which of the following type of mammogram is commonly done in a present practice? Answer will be digital mammogram. Now, what is this conventional film screen, digital, and tomosynthesis? The detailed theoretical part, we'll have a separate section for that. At this point, we should know, if I have to tell you in a crude way, conventional film screen mammogram is something like somebody taking a photograph through a micromax camera. Digital mammogram is like somebody taking a photograph through iPhone. And tomosynthesis is like somebody taking a photograph with a DSLR. So you can appreciate that the finer details will be better seen in a DSLR image, obviously. So out of these three types of mammogram, again a question asked in exam. This is the order of sensitivity of the mammograms. Tomosynthesis is the most sensitive way of mammography. Right? What is coming up in the further on this? At this time, it is tomosynthesis. Now, tomosynthesis is the most sensitive way of doing a mammogram, but commonly what we do is digital mammogram. So, language, as I said in the exam, is the key. Commonly, we are doing this, but preferred will be this. Why we are not doing this commonly also when it is preferred? The reason is it is not still available in many centers. So preferred is obviously tomosynthesis, but commonly which is available thing we do is the digital one, right? If you have a tomosynthesis available, it is better to do a tomosynthesis. In simple terms, tomosynthesis is like a three-dimensional reconstruction of this X-ray image where we, with the graphics, we peel off the skin of the breast and then the inner details becomes quite easier to appreciate. Now, with this understanding, let's talk about basic points here. I know most of the basic points you know here, but still I want to be very sure because we have to have a strong base. Ultrasound. Now, if I ask you, can you find out a lump in the breast through ultrasound? Yes or no? Your answer is definitely going to be yes. Can mammogram tells us that there is a lump in the breast or not? Answer again will be yes. There is a change in architectural pattern in a breast with a lump, so mammogram can tell us. Now, can a ultrasound tell us whether there is a single lump or a multiple lump? Yes or no? Obviously yes. When it is telling us about a one lump, it will not refuse to tell us about the other lumps. So obviously yes for both. Then we start having an issue, which I know is not for ultrasound though. Can ultrasound tell us whether the lump is solid or cystic? Yes or no? We know that. I know also, you also have the idea that it can differentiate solid from cystic. But if I ask you about a mammogram now, there we find some confusion. Now, we are confused whether a mammogram can tell us about solid or cystic. Answer here also is yes. But mammogram is not that good a modality as ultrasound is to differentiate solid from cystic. Then comes another very important thing. Can ultrasound guide us to do FNA? Can ultrasound guide us to do FNA? You know this. Without any confusion, I know your answer will be yes. But if I ask you about a mammogram, now you are again confused. We need to know this. Can mammogram guide us to do FNA? Answer is yes here also. See, just because in your text many times you have seen written ultrasound guided FNAC, so you answered ultrasound very easily that it can guide us. But just because you have not seen that there is anywhere written mammography guided FNAC, just because you have not seen, that does not mean that mammogram doesn't tell us. So mammogram can also tell us whether we can proceed to FNAC or not. So it can also guide us to do FNA. Now, this is not a problem for mammogram this time now. Can mammogram differentiate a benign lump from a malignant lump? I know your answer will be yes. But can ultrasound differentiate benign from malignant? Again, you are confused. Answer to this also for ultrasound is yes. What are the features of benign lump on ultrasound? What are the features of malignant lump on ultrasound? What are the features of malignant lump on mammogram? What are the features of benign lump on mammogram? Will be a point of discussion in theoretical part. But at this time, we should know it can tell us both. Now, these are the similarities. Now, what is the difference? Now, one major difference, which we all know, is there is no radiation exposure in ultrasound. There is a radiation exposure in mammogram, right? Then another major difference, it is less sensitive. It is more sensitive. Less sensitive, more sensitive. Then another difference is it is subjective, it is objective. What does that subjective objective means? Ultrasound, we all know, is a real-time investigation. My impression of ultrasound on a particular patient's pathology can be different from your impression. It has an observer bias. While mammogram is nothing but an X-ray of the breast. You carry that X-ray film. Everybody can make the similar impression. So mammogram has the objectivity involved, while ultrasound has a subjectivity issue. So with these understanding about the similarities and the differences between ultrasound and mammogram, if I ask you a question now, we have already understood that we should always do the basic non-invasive investigations if a issue of non-invasive investigation comes. Now I am asking you a very simple question, will be now for you to answer this. If given a choice, I am not providing the profile of the patient to you. The profile of the patient is not known. This was a question in exam already, and students were struggling on this question, and there was a question circulating in the media, various social medias, and you are trying to find out the answer. Here, with this understanding, you will get empowered and you will yourself find out the mistakes or a right answer itself. Now, if the profile of the patient I don't provide you, and I'll tell you that you have these two investigations also at your disposal, ultrasound and mammogram. Which of them you will prefer doing? Think about it and then answer. Your answer definitely is going to be that investigation which is more sensitive, which has a objectivity. So we should understand this basic point first. In a given situation, we should always prefer, out of ultrasound and mammogram, always mammogram. But having said this, there are certain limitations to a mammogram also. So we should know what are the limitations of a mammogram. The limitations of a mammogram are: 1, pregnant female. And the reason we all can make out radiation exposure. Second, young and lactating female. Young and lactating female. Why young and lactating female? In a young and a lactating female, the breast architecture is quite dense. As the age of the female progresses, the density of the breast decreases. It is usually at an elderly age, the breast is less denser. At a young age, the breast is quite denser. So seeing a change in architectural pattern in a dense breast, you can see it in this image also. Seeing something in a wide background, a white thing in a white background is difficult, while it is quite easy in a less dense breast. So in a younger and a lactating females, since the breast is denser, so seeing a change in architectural pattern in these patients is difficult through mammogram. Then the fourth limitation of a mammogram is previously operated breast. If the female has underwent surgery in the past on her breast, and if you are doing a mammogram, because of the surgery, there is going to be inflammation. Every inflammation is followed by fibrosis, so there will be change in architectural pattern. So mammogram finds it difficult to make out whether this change is actually a new change which has happened, or this is a change because of the previous inflammation. So these are the limitations of a mammogram. So what we can infer from here, what we have just understood, that in a given situation out of ultrasound and mammogram, if we don't know the profile of the patient, we will always prefer mammogram. But if the profile of the patient provided is any of these, we have no choice but to prefer ultrasound. Now comes another issue, and that is also a major issue. Every female thinks that she is young. So what is the definition of a young female? Right? So as per the latest guideline, this is something latest here. Since the time we have started doing a digital mammogram and tomosynthesis, the age of a young female has changed to less than 30 years. It was 35 years. Mind it is now 30 years. So less than 30 is considered young, more than 30 is considered not young. So you can also make out that how far you are from being called young. You can call yourself young till whatever age, but then this is the present guidelines, right? Now, please don't confuse it with a screening. We are talking about a diagnostic mammogram. Less than 30 years is the age for ultrasound. For more than 30 years is the age for a diagnostic mammogram. Now, what is the screening protocol age? We'll discuss when we talk about the screening thing. So, with this understanding, now let us get on now with the, now is the time to make out the approach issue here. Now, imagine a female comes to you with a complaint of breast lump. Breast lump. Now, again, we have to understand the language of the question. Very, very important point. In your exams, most of the time, they play with the language of the question. So, what is the language issue we should understand here is most appropriate next step. Appropriate next step. Next step. Next line of investigation. Most appropriate next step, appropriate next step, next line of investigation. These are the different languages of a same question. The answer to this question, any of this will be same. We need to know. Very commonly I get these questions through mail. So we first have to understand this language issue. Now, a female comes to you with a complaint of breast lump. What will be your most appropriate next step, next line of investigation, and appropriate next step? Your answer definitely is going to be, we should always do clinical examination first. Now, what is the practical aspect here? We should incorporate the practical thing also here. We primarily examine breast in sitting and supine position. These are the two positions in which we commonly examine breast. Then we ask the patient to do certain maneuvers to see the changes on the skin, like we ask the patient to raise her hands above the shoulder, we ask the patient to press her hands against the waist, then we ask the patient to bend forward to see whether the lump is falling forward or not. All those maneuvers we need to do to see various aspects associated with the lump, but the basic position is sitting and supine position, again a question in exam. Now mind it, this is the position of the patient, not yours, right? Now how do we palpate a lump? The lump should always be palpated with the flat of your fingers. You should never palpate with this surface of your hand. You should never palpate with the tip of your fingers. You should always palpate with the flat of your hands, again a question in exam. Now there are various methods to palpate breast. What are the various methods? We should know. There is a dial of a clock method. There is a vertical line method. There is a radial spoke method. There is a concentric method. There is dial of a clock method, vertical line method, radial spoke method, and concentric method. The basic point, see, try to understand one thing here. Breast lump, breast examination, carcinoma breast is the most common malignancy in females now. So whenever we are examining breast, we have to make sure that we examine whole breast and we should not miss any part of the breast. So there are various ways to examine. Dial of a clock. This is a dial of clock where we divide the breast into various dials of the clock. 12 o'clock as the upper point, there is 6 o'clock, then there is 9 o'clock, and we start from the 12 o'clock and then go to collect clockwise and reach to the 12 o'clock position, and then we go to the axillary tail. Likewise, there is a radial spoke method. We start from the center and then go to the periphery, and then likewise we see the whole breast. And then the concentric, we start from the periphery and then comes to the center, or we start from the center and then go to the periphery, and then there's a vertical line method. Now these are the various methods. The basic point is we should not be missing on any part. So any particular clinician, it is said that he or she should adapt a one particular method so that they get acclimatized to this one particular method, and they are routinely doing that. So there is no one method which is good or bad, but commonly in most of the centers we do use a dial of a clock method. So can be a question in exam. There was a GIF file where they shown in exam the dial of a clock method, but then basic point is whole breast should be examined in totality. So these are the four methods which we use for examination of the breast. So again, a clinical aspect. Now correct me if I am wrong. On clinical examination, it is quite possible that there is a lump. On clinical examination, there is no lump. Your patient has come to you with a lump, but on clinical examination, there is no lump, because it can happen that lump is not there on clinical examination because you know it's to be palpated through a flat of your fingers. If the patient is examining with the tip of the fingers, can confuse a normal nodularity of the breast with a lump if there is slight pain happening in the breast. So it can happen that there is no lump. It can also be there that there is lump. So what if the lump is not there? What will be your most appropriate next step? Next line of investigation, appropriate next step. Again and again, I'm specifying this. Your answer should be, first of all, as we know, we don't want to miss on anything, right? So it is quite possible that there is something we fail to see. So we should always go ahead with the radiological investigation. And what that radiological investigation, what I told you, we always go ahead with the basic radiological investigation. We are talking about a normal population patient, right? So how the things changes, the basic base remains the same. In further high risk pregnant, there are going to be certain things added, but then the basic thing remains changed. So we have to first know the basics. So we do radiological investigation. What radiological investigation? If the profile of the patient is not provided, we know now it should be mammogram. But yes, if any of the four are there, we will do ultrasound. So ultrasound or mammogram. Right? Now it is quite possible that we may find a lump on ultrasound or mammogram. We may not find a lump on ultrasound or mammogram. Now let us first finish off this part. A patient has come to you with a lump from a normal population patient. On clinical examination, there is no lump. On radiological basic investigation also, there is no lump. Now, since this patient is a normal population patient, we have no added suspicion of anything. We will now advise this patient reassurance and tell her that there is nothing to worry about, but you can still be with us in follow-up. This is a normal. Now, how the things changes in high risk, we'll figure out, right? Now, then comes lump is clinically palpable. Very, very important question, and commonly answers given in some of your books are not right on this. So we have to know the right thing here. When the lump is palpable, what is the next step? The guideline on this says the next step here also should be radiological examination. Now, you must be wondering, that lump is there with us. Why do we need a radiological investigation? We can directly insert a needle and get the diagnosis. But it is not like this. Now, let's understand this, because understanding the concept is more important here. Just mugging up things. I'm one of those who just doesn't believe in mugging up things. We need to understand the concept, because language in exam is the key. So you have a lump on your clinical examination. Now, why did you do radiological investigation when the lump was not there? Just because you thought there can be a lump inside. Probably you may have missed it. So you don't want to take a chance, so you went ahead with the radiology. Now here, when the lump is there, why do you think this is the only lump patient has? Patient may be harboring a multifocal disease. Patient may be harboring a multicentric disease. Again, a question in exam, what is multifocal? What is multicentric? Multifocal is one when there are multiple primaries in one quadrant. Multicentric is one when there are multiple primaries in multiple quadrants. Right? Now, so to know about this multifocality and multicentricity, we should be doing a radiology. Right? So we understood now that we should be doing a radiology. So what we understood, that radiology should be in a loop of things to rule out multifocality and multicentricity, because if you just focus on this lump and without ruling out multicentricity and multifocality and you treat this lump only, this will be under treatment for the patient. So what we have understood, that radiology should be in the loop of investigation, but this still doesn't answer the thing that why radiology should be the next step. This is important. See, you know that radiology should be in the loop of things. The basic radiology we know is always the thing. So you decided that I will do radiology. Let me first do a tissue sampling in the form of FNAC or true cut biopsy. These are the two things we have for invasive investigation available. So you send the patient for, imagine, the invasive investigation in the form of true cut biopsy or FNAC. So whatever route the pathologist find it easier to reach to the lump, the pathologist is going to insert the needle there. So pathologist can reach to that lump like 1, pathologist can insert the needle like 2, pathologist can insert the needle like 3. Now, correct me if I'm wrong. The track through which the needle is going to go, won't there be inflammation? Won't there be bleeding? There will be inflammation, there will be bleeding. And every inflammation is always followed by fibrosis. So if you have gone like 1, so if there is a fibrosis, there will be change in architectural pattern. So if the pathologist has gone like 1, there will be change in architectural pattern like this now because of that tract. If the pathologist has gone like 2, it will be like this. If the pathologist has gone like 3, it will be like this. So there is a change in architectural pattern already because of the lump. Just by doing an invasive investigation before radiology, you have unnecessarily made the problem multifocal or multicentric. So the guideline says, be the lump palpable or not palpable, the next step after clinical examination remains basic radiological investigation, that is ultrasound or mammogram, depending on those 4 things. A question asked was, this was a question which I am talking about and the answer in your book is not right. A 45-year-old female comes to you with a hard lump in her breast. What is the most appropriate next step? The answer given in your book, in one of the book is FNAC, in another book is true cut biopsy. This is not a right answer. The guideline says we should avoid doing an invasive investigation before radiology. So answer will be mammogram because the age is more than 30 years. So what we can infer from here, that we should always do clinical examination first, then we should always do radiological examination. Now this is something very important and this is the key. Listen to this carefully first and then write down and try to understand first. The guideline says, be it on clinical examination or on radiology, be it on clinical examination or on radiology, if you have a slightest of suspicion of malignancy, the next step should always be true cut biopsy. Be it on clinical examination or on radiology, once you have a slightest of suspicion of malignancy, the next step should always be true cut biopsy. And this true cut biopsy in this stepwise approach is a showstopper here. That is now called the investigation of choice. So this is the bridge which we have to climb over to get that gap filled. Investigation of choice for breast lump if asked is true cut biopsy though, but it may not be the next step when the patient comes to us, right? Now in our hospitals, many times we see a FNAC getting done. Now what is a present status of FNAC? Now what I just said, be it on clinical examination, be it on radiology, once we have a slightest of suspicion of malignancy, the next step will be true cut biopsy. Now before I tell you about FNAC issue here, what does this mean? Because we have to know the concept. Clinical examination. Now imagine a patient comes to you with a clinical examination, you have a hard lump. We know that soft like this, firm like this, hard like this. So once there is a hard thing on palpation, we know we should be suspecting a malignancy because malignancy have a very intense fibrotic reaction because of which they are hard. So once there is a hardness, you have a suspicion. Then we have to go to the radiology. And in radiology, imagine radiologist said that it is a benign thing. There is a BI-RAD score also, which is the radiologist opinion on the radiology finding. What is BI-RAD score? Breast imaging reporting and data system. We'll be discussing in our theoretical discussion how BI-RAD score is, has implications here. We'll discuss later. But then what I want you to understand here is BI-RAD score is a radiologist opinion, which we'll be discussing about. Here on clinical examination, we have a suspicion of malignancy. Radiologists are saying that it is benign. So since we have a suspicion of malignancy, we have to do a true cut biopsy. So either of them. So imagine on clinical examination, there is a firm lump which is highly mobile in the breast, having smooth surface, well-defined margin. We have no suspicion of malignancy in such lump. But at the same time, we know not all firm lumps are benign, not all hard lumps are malignant. So we go ahead with radiology. So radiologists this time said there is a suspicion of malignancy. So what to do? True cut biopsy. So this is how the things are incorporated here. Now, what is a present status of FNAC? Very commonly in our OPDs, you see we are getting FNAC done. Now, what is a present status as per the guideline? It is said that it is a historical importance here, but then what is still, when is still done? The guideline is very clear on this. It says once on your clinical examination and on your radiology also, if you have no suspicion of malignancy, it's a clear-cut benign thing, you can then go ahead with FNAC. Only then. Clinical as well as on radiology, if there is a clear-cut benign, then we can think of doing FNAC. Second indication where we do FNAC in a present time, imagine there is a lump in the breast and you found out that it is multicentric. There is one prominent lump and there is other lumps which you came to know through radiology. So for this prominent lump, you are doing a true cut biopsy. For others, if that prominent lump is a malignant lump, for others, we may do a FNAC to find out the nature of that the lesion, right? Then the third indication of FNAC in a present arise when the lymph node in the axilla are enlarged to find out whether these lymph nodes are enlarged because of the metastasis or no metastasis. So these are the three indications of FNAC. Otherwise, whenever we have a slightest of suspicion of malignancy on clinical or radiology, the next step is always true cut biopsy. So for this very reason, true cut biopsy is the investigation of choice for breast lump. And now we know on true cut biopsy, if we find any of those things which we have discussed, then we may need to do excisional biopsy. So now let us bridge another gap. Gold standard investigation in breast lump if asked, it will be excisional biopsy. Gold standard is the best one, but we know we don't need to go to excisional biopsy if we have no issues or if we don't have those findings on true cut biopsy. So this is the bridge which we have to climb to understand the theoretical and the clinical aspect. Now let us summarize it here. So what we have done a clinical examination always first. Then we do a radiological investigation. And after that, we do either FNAC, depending on very less occasion are there where we do FNAC now, or we do true cut biopsy. These three things together, when done, this is called triple assessment. This is called triple assessment. This word of triple assessment has come here just to emphasize on a fact that we should not embark on a excisional biopsy upfront without correlating the three. If all the three are in accordance with each other, we have a diagnosis established. This is called triple assessment. So triple assessment includes clinical examination, radiological examination, and tissue sampling, and that tissue sampling is either FNAC or true cut biopsy. And when we correlate the three, the sensitivity of triple assessment, again a question in exam, is 95.5%, while the positive predictive value, again a question in exam, is 99.9%. Now, having said this again, we know it now. If there is any discrepancy between the three, we may need to do excisional biopsy. So, triple assessment does not include excisional biopsy. This is something basic of an approach to a normal. Now, once we have this base, then only now we can graduate to the nitty-gritties here on radiological examination. What is BI-RAD score? How, when we have a benign finding, what we are supposed to do here in the radiology, how the thing goes in a high risk patient, how the thing goes in a pregnant female. Now will be our, we are ready to swallow or digest those things. Without understanding this, if we talk about, this is not the way I go about. Now, if I ask you questions, you should be able to answer this question. And this was a question in exam also. A 45-year-old female comes to you with a hard lump in her breast. Which of the following is most helpful in diagnosis? 45-year-old female comes to you with a hard lump in her breast. Which of the following is most helpful in diagnosis? The choices are ultrasound, mammogram, true cut biopsy, excisional biopsy. Think about it and then answer. You know the concept. Answer definitely is going to be excisional biopsy. See, try to understand here. This is not an approach based question now. This is a question about most helpful. Most helpful is the one which is the best. And that best here, the gold standard is excisional biopsy. It is just another thing that we don't go to excisional biopsy, but we may need to go to excisional biopsy. We have understood. This is what is the basic thing about a clinical and the theoretical part. So this is what we need to understand.